you could join us. Today we have 3 exciting sessions and 3 moderators to assist with us. My name is David Burke, and these sessions will be on physical activity and nutrition, the role of PM&R in healthy aging, and falls and injury prevention. Again, I am Dr. David Burke. I'm in Atlanta, Georgia, in the United States. I'm a professor of PM&R at Emory University and specialize in brain injury. So my colleagues are.
Hi everybody, Assalamu alaikum. I'm Dr. Ahmed Saad Hassan. I'm physical medicine rehabilitation and pain medicine management physician. I'm assistant professor at National Rabat University from Khartoum, Sudan. I'm the head of rehabilitation department in National Rabat University. I welcome you again.
Hello, everyone. Un saludo a todos desde Honduras. My name is Maria Fernanda Calderon from Honduras, and I am a physiatrist and professor at the Rehabilitation Department at La Universidad Nacional Autónoma de Honduras in Tegucigalpa, and I'm also country ambassador to ISPRM World Youth Forum. Welcome to everyone.
Wonderful. And our first speaker will be speaking on physical activity and nutrition.
Okay, I just want to remind everyone that additional files for today's sessions are available at the Hangouts icon. It's near the chat. If you can download any additional files from it, and please feel free to use the question features if you want to ask speakers if you need any assistance. All the sessions will be recorded and you will be notified once the material is available at your access. You're welcome.
So we will be our moderators for today, and we are supported by the ISPRM office as hosts by Jessica Edie and Nicole Carlucci. They're backstage.
All right, and now we can begin our first session.
So we're going to start our first session today on physical activity and nutrition. Our speaker is Professor Paolo Capodaglio. He received his MD degree from the University of Pavia, Italy, and his specialization in PRM from the same university in 1991. He worked in different hospitals of the Fondazione Maugheri Institute with clinical and research interests. He was abroad for long and short visits in 1992 at the University of Dusseldorf, and from 1995 to 1996 at the National Institute of Occupational Health in Copenhagen, Denmark. Thereafter developed collaborations with several research groups in Europe and the US. He is associate professor in PRM at the University of Torino, Italy, and director of the rehabilitation unit with 70 inpatients, the physiotherapy unit, and the laboratory for research in biomechanics and rehabilitation at the Istituto Ausológico Italiano, ERCCS, in Piancavallo, Italy. He chairs the ISPRM Special Interest Scientific Committee on Rehabilitation of Metabolic Conditions, is member of the ISPRM Clinical Sciences Committee, and associate editor of Frontiers in Rehabilitation Sciences. He has devoted most of his research to the functional evaluation and aging in pathological conditions such as spinal cord injuries, musculoskeletal disorders, and in the last 15 years, obesity and metabolic conditions. He has published more than 200 papers on peer-reviewed journals and 6 monographic books, invited speaker at several international rehabilitation congresses, and recently at the virtual ISPRM 2021 and 17th Panhellenic PRM Conference. Hope you're excited, as I am, to watch this presentation on physical activity and nutrition.
We are living longer, but quality of life is not keeping pace. Two big factors affecting individual health are nutrition and physical activity, which are both to a large extent jeopardized by our contemporary lifestyle. My talk, I will try to briefly go through some of the cornerstones of a correct nutritional and physical activity approach in the elderly, and I will try to underline the possible synergic action and the common underlying molecular pathways. Nutrition affects every cell, tissue, and system in the body. Nutrition includes calories, macronutrients of protein, fat and carbohydrates, vitamins and minerals, water, fibers, and so on. As we age, food choices, changes in lifestyle and living situation, and physiological changes make it even more important that we consume a nutrient-dense diet, one that provides us with all the nutrition we need, but not the excessive calories that result in unwanted weight gain. Nutrition risk, weight loss, or malnutrition has been associated with a variety of negative health outcomes in older adults, like risk of delirium, depression, falls, impaired function, mortality, poor surgical outcome, longer hospital stay, and readmissions. Determinants of food intake influence what we eat. Determinants include living situation, income, mobility and ability to lift objects, tolerance for activity, gastrointestinal functioning, access to transportation and to stores, education, knowledge of nutrition, knowledge about food or cooking, food preference, culture, and so on. When determinants limit the types, quantity, or nutritional quality of food consumed, this can lead to intake that does not meet recommendation or individual requirements. Weight changes can be an early sign of these changes. As those changes continue, or disease or injury causes inflammation in the body, the older adult can become undernourished. Undernutrition is evidenced by a significant weight loss, loss of muscles and or fat, changes in function, for instance, weakness, tiredness, low tolerance, poor cognition, and these consequences can include morbidity such as falls, hospitalization, and so on. The diagnosis of malnutrition is defined by the GLIM criteria defined in 2019 by this panel of experts. Inadequate nutrition, especially protein intake, can cause, of course, sarcopenia. And that, as you can see in this slide, but that means also that in sarcopenia, a malnutrition condition should be always suspected and investigated by applying the GLIM criteria. Diet and exercise do activate a molecular signaling hub, which is known as mTOR, which actually boosts protein synthesis. From the nutritional point of view, particularly inadequate amino acid intake can activate mTOR because often insulin resistance, which is commonly present in the elderly, can hinder this pathway. Also, muscle contraction, particularly resistant training, can also activate the mTOR signaling hub and ultimately the protein synthesis. But which exercise should we recommend in elderly subjects? Of course, in a real world setting, we should always recommend NEAT, non-exercise activity thermogenesis, which can increase basal metabolic rate. Suggesting NEAT means suggesting elderly patient to stand up for longer time, to walk, to take stairs instead of the elevator, and that will increase basal metabolic rate. But we are particularly talking about resistance training, so resistance strength training with the overload principle, with body weight, and with elastic bands. In sedentary elderly, every stimulus can be effective, and aerobic exercise itself is a sufficient stimulus to overload muscles, thus eliciting adaptive responses. Initial hypertrophic response induced by aerobic exercise may be secondary to quantitative and qualitative mitochondrial adaptations. It is therefore to encourage the accumulation of moderate to vigorous 10-minute bouts of physical activity by increasing steps of ambulatory movements rather than focusing solely on structured form of exercise. Higher intensity are difficult to be achieved on land, but we have to remember that in water, the immersed subjects can exercise vigorously and is capable of increasing, for instance, VO2 max over relatively short periods. So if land-based high-intensity interval training is difficult to perform in elderly, obese subjects, aquatic, short-term, low-volume, high-intensity training is possible, is feasible, and is time-efficient. So that in mind. Elderly also needs a higher amount of protein intake than young subjects to stimulate muscle protein synthesis. The dotted line represent the maximal muscle protein synthesis that can be achieved with protein intake after resistant training. The dashed green line represents younger subjects, and the dashed blue lines, elderly subjects. Solid line represent protein intake at rest. The red line is the response in muscle protein synthesis after protein intake in the immobilized muscle. So clearly from this slide, you can see that a combination of resistant exercise and protein intake generates higher muscle protein synthesis. And also that elderly need more protein intake, a higher protein intake. They need a total of 20 grams of protein intake, 0.4 grams per kilo per meal, whereas younger subjects need 4 times less and need a 5 gram protein intake. Also the distribution of the dietary protein intake every 3-4 hours, the so-called spread diet, leads to a higher protein synthesis rates, and it is associated with higher muscle strength, physical performance, and skeletal muscle mass in older subjects. So spreading the protein intake over breakfast, lunch, and dinner is better. In conclusion, a balanced diet with carbohydrates, protein, and lipids, and proper hydration is important in achieving good physical performance. Leucine is the essential amino acid most triggering muscle protein synthesis, as shown in the literature. And we want to emphasize the correct integration of diet and physical activity that will aid recovery from illness and help protect against health problems. I thank you for your attention. Thank you.
Thank you. And unfortunately, Professor Capodaglio cannot join us for his question and answer session, so we have sent him some questions. And you're welcome to write yours as well in the question section, and we'll ask him to answer these later via email. They'll be posted on your page later. So do we have the answers to his questions to post?
Regarding the first question we asked him, it was regarding the vegans or the vegetarians. Is there any difference in the protein daily requirements, and does it differ in their muscle disposition? Professor answered, the protein daily requirement is the minimum protein intake able to maintain the protein masses of the body. Such requirements able to meet the needs of 98% of the general population has been estimated by 0.83 gram per kilogram body weight. For vegetarians, it's important to underline that their diet can be well balanced and able to provide all the macro and micronutrients essential for the health and differently from diets including animal proteins. Vegetarians' diets can show positive metabolic aspects with a reduced tendency to overweight or obesity, and for hypertension, dyslipidemia, and cardiovascular conditions, such as also for cancer and diabetes. Nonetheless, they can associate sometimes with unsatisfactory protein intake. In fact, proteins of vegetables origin are less digestible, and because they contain fibers and anti-nutrients, such as the trypsin inhibitors, which reduce protein absorption. Comparable of that of the animal proteins. It's lower by 80 to 90% with cereals in grain and legumes, and even lower by 50 to 180 in vegetables. Therefore, despite the metabolic protein needs of vegetarians does not differ from non-vegetarians, it appears advisable to increase by 5 to 10% as compared to the LRN, the minimum recommended protein intake for the general population. Such quantities are provided by the daily consumption of all different vegetables, even in conditions requiring high intake, such as the elderly, the pregnancy, and children. However, proteins from vegetables have a lesser anabolic effect on muscle mass than those from animals because of lesser content in leucine and of lower absorption digestibility coefficient. Animal proteins are more effective in inducing muscle protein synthesis. Vegans should consider integration with protein of vegetal origin with leucine levels similar to those of animal proteins, because vegans' diet seems to be less effective in stimulating protein synthesis. Thank you for this answer. Can go to the next question.
The second question we prepared for Dr. Capodaglio was, what is the time relation for muscle recovery between patients with combination of protein intake plus muscle resistance training and a muscle resistance training program alone? And the answer was, there is a consolidated evidence that the combination of resistance exercise and protein intake generates higher muscle protein synthesis than training and muscle resistance program alone. Also, the daily distribution of dietary protein intake every 3 to 4 hours, called a spread diet, leads to a higher protein synthesis rates and is associated with higher muscle strength, physical performance, and skeletal muscle mass in older adults. Elderly subjects need a total of 20 grams of proteins a day, whereas young subjects need 4 times less, 5 grams. Resistance training is used to increase lean mass, strength, and physical function. Strenuous resistance training can evoke damage or deformation to the working muscle, limiting its capacity to produce force. This may persist for hours or days before full recovery, reducing general muscle function. During any subsequent training or performance, a reduction in muscle function can impair the quality and intensity and is potentially injurious to the athlete. Protein ingestion is thought to enhance peri-training recovery for muscle function because of protein supplements facilitated improvements in net protein balance may promote muscle remodeling and speed the recovery of muscle function, which in turn could improve the quality of subsequent training or performance demands. Milk-based protein supplementation immediately after a bout of damaging exercise like maximal lengthening contractions has been shown to attenuate decrements in muscle strength after exercise. Recovery from exercise has been measured through many different methods in different studies. Delayed onset muscle soreness, which is defined as the aching pain in a given muscle following a novel exercise bout, has been measured subjectively. Specific biomarkers like creatine kinase and muscular protein synthesis rates appear to be most efficient and widely used methods of objectively determining muscle breakdown, recovery, and adaptations from exercise. Post-exercise muscle biopsies can be used to determine rates of protein synthesis, which directly measures the magnitude of the recovery process immediately following exercise. There is evidence that 4 grams of protein stimulates protein synthesis to a greater degree than 20 grams following whole body resistance training, showing that protein intake is a key factor for muscular recovery, but the ideal amount of peri-exercise protein consumption depends on many factors, including total caloric intake, total daily protein intake, daily status of the individual, age of the individual, muscle force, type of protein consumed, type and amount of the other nutrients consumed, and the composition of and timing of most recent pre-training meals. It has been demonstrated that the ingestion of proteins following a damaging eccentric resistance protocol helps to attenuate the expected decrements in strength and repeated sprint ability for 20 to 72 hours following the bout. Recently, a group of researchers found that whey protein can facilitate muscle recovery following an intense isotonic exercise bout as well, and that is more than an issue of caloric replacement. Recently, the efficacy of whey protein hydrolysate supplementation on reducing markers of muscle damage and accelerating recovery has received attention in the literature. For these reasons, it is clear that a diet that provides a correct protein requirement, which could also be achieved through the use of protein supplements, is able to determine a better muscle recovery, and it could also accelerated after resistance training than a diet lacking in protein components, and overall there appears to be no adaptive advantages to avoiding protein intake in the peri-workout period.
Very good. Now, the other questions will be answered online if you want to email further questions. So let's move on to our next speaker, Dr. Professor Fo.
Okay, our next talk will be, so with the next session today, it will be the role of PRM in healthy aging. It will be by our speaker will be Professor Stephen Fo. Professor Stephen Fo is the Director of the Department of Rehabilitation and Pain Medicine at St. Vincent's Hospital, Sydney, and Conjoint Co-Professor of Medicine at the University of NSW. Professor of Medicine at the University of Notre Dame. He leads a department with the cases of over 50 public rehabilitation beds up to 80 private rehabilitation beds and have led a number of multi-site rehabilitation RCTs in New South Wales and access to over 120 rehabilitation beds. He has authored over 90 journal articles and received the Kuwaiti International Excellence Award of Patient Safety. Professor Fo has conducted trials in device development for rehabilitation and has been funded by Australian Research Council grants for research into smart glasses for determining activities of daily living for patients with acquired brain injuries and in hospital falls prevention device. He has completed Australian first data linkage project in stroke rehabilitation with Australian Rehabilitation Outcomes Centre and the Australian Stroke Registry, and has developed a patient education module for the use of virtual reality in stroke, and has completed a number of international RCTs in the management of post-stroke spasticity. I think now all of you are excited to watch this presentation, so let's start our brief presentation of PRM in healthy aging. You are welcome.
Good evening or hello. My name is Stephen Fo. I am a professor of rehabilitation medicine in Sydney, Australia, and I want to thank the ISPRM for giving me an opportunity to talk about healthy aging from an Australian point of view. We're far under the world, but we feel still a part of it, and we'd like to talk a little bit about healthy aging from our point of view. Slide, please, Jessica. So what do rehabilitation physicians do? Well, we focus on helping people remain independent. That's the main thing that we do, is we try and make people function by themselves without assistance. Now, as we get older, sometimes it is more likely that we will get chronic diseases like diabetes or hypertension. There are some diseases that we don't get more of just because we get older. For instance, asthma is the same in older age groups as it is in younger age groups. But as we develop diseases, we need rehabilitation to recover well, so that we can maintain our health and we are able to keep as independent as possible for as long as possible. And what do I mean by independence? I mean that we're able to do everything for ourselves and we don't need to rely on other people. And we know that makes people have a very good self-esteem and feel very good about themselves. Slide, please, Jessica. So a rehabilitation physician leads a whole team of therapists and nurses and doctors whose aim is to help people recover and become independent. So if a person falls and injures themselves, physiotherapists will help get them up and about. If they're recovering but need to get back into their home, occupational therapists will help them get back into their home and develop their confidence. And as doctors, we check to make sure that conditions that are painful or conditions that make people feel sick or unwell are best managed. They have the right medicine or the right treatment to not suffer from pain or difficulty, so they can return to what they like doing, such as spending time with grandchildren or just being able to walk on their own. Slide, Jessica. So aging relies on adjusting to change, and that is what we call resilience. So resilience is a person's ability to recover from or adjust easily to change or misfortune. And as we get older, we have to adjust to changes all the time because our bodies change and the world is changing. So to age well, you have to have the capacity to adjust to change. Slide, Jessica. So healthy aging depends on our capacity to reignite our resilience. And we are resilient because we have survived into old age. So we need to maintain our health in order to maintain our independence. And rehabilitation physicians lead teams of healthcare workers to help older people stay independent, particularly if they've hurt themselves or suffered an illness. Probably the most important thing is if we're independent, we become relevant and necessary for our families. Maybe we need to help look after children or help look after people who are working. If we're independent, we can help our communities, we can help social groups, or we can do voluntary jobs, or we can look after the areas that people come to meet. And in our own countries where we live, if we're independent and resilient and strong, we can influence people who make decisions about politics or the way the world is structured through the community with our wisdom, because we always have the power to influence who might be elected or who might have the best idea about how we should live together as a group. Slide, Jessica. So we have adjusted constantly through our lives. Women have had to adjust when they have children. They've had to cope with a changing body and also the raising of a child. And we know that child mortality has improved through the world because we have all changed the way that, or women have changed the way they've had children. We've all got through our childhood because we've had the luxury of immunisation and good health as a child, and that is another change that we had to undertake. There have been changes in public health to water and sanitation, education and health systems, and we've had to manage that. We have to keep clean water, and we have to make sure that sanitation's been properly looked after, and we have adjusted to that, and therefore we've moved further to be able to manage some of the other challenges such as poverty or need to find good housing or nutrition, managing mental health or family violence, and now we have to manage the changes in our climate. So just becoming older means you are definitely resilient. Slide, Jessica. So rehabilitation plays a role in helping to promote resilience, because as we get older, then it's more likely that we will have some sort of a disability. The disability might be arthritis or pain or walking a bit more slowly, but we have to adjust to changes in our health. So rehabilitation physicians help people find their best level of function. So how would they be able to look after themselves with or without that disability? And we do that by training, physical training, educating, and also teaching families and carers how to manage or help an older person stay independent. But probably one of the strongest roles we have is we advocate in the community to help people age properly and to help them age in a healthy way. Slide, please. So we make sure, for instance, that trains and buses and public transport have an easy way of access so that older people can actually get onto trains and buses more easily. We make sure that if there's toilets in public places, that older people can get on and off those toilets. And we also make sure that the shopping centres are easy for older people to get to, and that things are placed in parts of the shopping centre that we can get our hands to more easily. So slide. And what we do is we also set up ways that people can remain independent in the community. So in rehabilitation centres, we set up exercise classes. We often do that in the swimming pool, if there's a swimming pool. If not, we organise classes of people outside to do exercises like Tai Chi. We teach older people about how to adapt to change, but probably one of the main things that we are teaching now is how to use information technology or mobile phones. This is very important as you get older. because this allows you to connect and get help. This keeps you independent. We often also do what we call home assessments. We send occupational therapists to the home and we have them check the homes out to make sure that people aren't at risk of falling over. And of course, we use our dietitians to make sure people understand how to keep a good diet and how to maintain their health through their diet. And in many cases, we will arrange food delivery if it's possible. Slide. So what we try and do in developing countries is we try and maintain families together and protect against fragmentation. In richer countries, families are often very fragmented. In middle-income countries, the families are very strong. And we know that healthy aging depends on having a good and strong family unit. It doesn't always have to be family members, but it needs to be people who are supportive and who you want to spend time with. We also develop programs to prevent the loss of memory or develop brain health, and I'll talk about that a bit later. We also make sure that if you do fall over or you trip, that your bones are strong and don't break. So we work on ways of preventing falls and also developing bone health. We also, in many countries, we try to avoid having too many medicines, and we give education on drugs and alcohol, particularly smoking and alcohol. Slide, please. So globally, in order to age in a healthy way, you need to undertake regular exercise. Walking is a particularly good exercise because it's weight bearing. It means that you make your bones healthy by carrying your weight. But sometimes swimming is easier for people who have sore joints. And you need to do this for at least 30 minutes a day. So rehabilitation centres can often provide systems and places that you can go to exercise. We encourage you to have a diet rich in vegetables and fruit, but also quite rich in proteins. Beans or chickpeas are vegetarian type proteins, as well as nuts. Fish and meat are proteins that are also of importance if you can get them. We try to limit the amount of fatty foods, such as fried foods, but sometimes that's not always possible. The other really important part of healthy aging is to engage socially. What that means is to spend times with friends and families and interact with them. We know that this maintains the brain and makes it harder for you to lose your memory. And we know that social engagement is also very good for the mood, and it helps you stay happy. So in some organizations, some areas of the world, laughter has become a very important part of healthy aging, and making sure that people have an opportunity to spend time together and share a story or a joke. In some cases, mental exercises such as playing games or chess or backgammon or doing crosswords keeps a person's mind active. And we know that if you isolate yourself and keep yourself away from the family, your ability to age healthily is affected. Finally, it's very important to maintain your cardiovascular health, to make sure that the blood going to your heart and brain is not impeded, which means you need to have blood pressure checks and a checkup with a doctor at least once a year if that's possible. We need to check cholesterol, and also if you do have other diseases, you need to be able to access special health care. If you can do this, you'll be well on the way of improving your ability to to age in a healthy way. Slide. I want to show you a program that was developed in the UK but was run in Australia as well, which showed the importance of intergenerational therapies, of being together with very young people, and it applied the principles I've talked about: mental training, social interaction, exercise and education. And Jessica, I wondered if you could play the YouTube video for 2 minutes now.
Go and sit down. Let's go, Neve. All right.
Wow.
We're going to paint the cups. Do you know why I'm thinking we should paint the cups?
Yeah.
Why?
To say goodbye to our older adults.
And then we're going to give it to them on the last day as a thank you present, and so that they can remember us.
Now, first I use it pink. I'm going to paint Rita. Miss Fiona, I need to do this because I want to paint the bottom.
Okay.
Receiving a gift that's handmade and that someone's put thought and effort into is extra special. It can show us how much someone else cares and knows about us and really values us.
Wow, look at that, guys. Doing an amazing job. I love them.
We know with time memories can fade, but having a keepsake can be a way of prompting and keeping some of those memories alive. And we want the memories of this experience to stay alive for our participants.
Ta-da!
And then it'll be a personalised drink bottle decorated by you guys. No fighting over stickers, please.
You can't have any.
Okay, so maybe
All right, I've got dinosaurs. Anybody wants dinosaurs?
wait.
I think she likes pink. She likes pink.
John's got some paint.
Is there any stickers of yoga anywhere?
No.
There's an incredible difference between them in terms of personality
Yeah.
and in terms of interest. You know, people tend to forget that 4 and 5-year-olds think very deeply about lots of things, you know.
I must say, I was talking about Maddie saying, you know, how with the age, but the other thing she said the other day is that, what is a good friend? And her answer was, a good friend is one who knows my joy.
Fantastic.
That's lovely.
And I sat there totally quietly thinking, why didn't I think of that? You
Yeah.
know,
That's so
we are all
beautiful.
looking for that, you know, someone to make us
that's
lift
so
us a little. And,
Absolutely.
yeah.
I tried to make it as colourful as possible, and I thought the most colourful thing that would come to her mind would be a rainbow. So I made a rainbow with her name featured in each little sequence of colour. Hopefully it'll be well received. It'll be interesting to find out what the kids think of the adults, and particularly Ika of me.
Fiona, can you write something inside?
Can I write something inside? What do you want me to write?
Dear John, I love you.
To John, I love you.
Yeah.
From Fiona?
Yes. From Aunt Me.
From you. Okay.
From Ika.
From Ika.
Done.
So, dear Ash.
For
Ash.
For Ash.
Yeah.
I'll miss you.
To Betty, I love you, Betty. Yes, I love it. What about some kisses or hugs at the bottom?
Thank you, Jessica. Next slide, please. You can see how in that video there was very, very important improvements in the aging of the older people by their contact with the children, as well as that there was great contact. It was great contact for the children, and it taught them better problem-solving skills. So it was a terrific intergenerational therapy. Rehabilitation physicians also help prevent falls in the community, because we know that getting older means your ability to balance is a bit worsened, and your speed of walking can be worsened. So rehabilitation programs which can be done at any stage and doesn't have to follow an injury or illness, strengthens muscles in the legs, in the thighs, teaches balance training, and checks for osteoporosis, which is the thinning of the bones. And as you can see from this diagram, the bones become more porous and more easy to break. We also remove hazards from the home and keep the medicines down to a minimum. The aim of that is to help walking speed, and also falls are prevented when vision and hearing are well addressed. And that's a very important part of healthy aging, to make sure you can hear people and you can see them well. And sometimes this means a visit to the doctor if possible. Slide. Slide, Jessica. Whoops. Yeah. So sometimes we talk about frailty as people get older, and frailty is where people start to decline physiologically, and they start to becoming more vulnerable to falls and loss of independence. And you can see from the diagram at the top here the difference in the way people look as they get older and more frail. But rehabilitation can actually reverse some of that frailty, and we do that by exercising the arms and making sure that the arms are strong as well as the legs, and aim to increase the walking speed and get people to do more and more physical activity so that they walk at a faster pace and they're able to have their breathing rate up a little bit. And the idea is that we would maintain their weight with a good nutrition, and also with the exercise and the strengthening of the arms. And if we do this, we can reverse that cycle and stop people from becoming more and more vulnerable. And again, this is done through rehabilitation and through general exercise, as well as good nutrition. Slide. We also now focus on keeping the brain healthy, an organ that we didn't really know how to address in terms of maintaining its strength and preventing the loss of memory as you age. And I've identified that vigorous exercise, so more than 30 minutes, quite a lot of exercise every day, would definitely improves blood flow to the brain, and it slows the loss of memory. We know that socialization, sitting with friends and talking, sharing a joke, also improves thinking and decreases the rate of memory loss. We've also encouraged people to do cognitive training or to play games like backgammon or cards, or crosswords or Sudoku, to actually keep their mind turning over, so that they're trying always to extend themselves rather than being isolated and keeping away from people. And of course, as we spoke of before, the importance of preventing stroke and heart disease by not smoking and taking preventative medicines such as aspirin, and also making sure that the blood pressure is under excellent control. And these are parts of healthy aging. So slide. So in Australia, we have developed a number of home-based rehabilitation services, and many of them are based on tele-rehabilitation, because Australia has is a very vast country with people very far away from one another, living in rural settings. Most people in Australia live in the cities, but a large proportion of people also live in the country areas, and it's not easy to get services to them. So in many cases, we've sent them devices such as blood pressure machines and pulse oximeters to take their readings every day, and we would phone people to find out how they're going. We've also developed what we call geriatric flying squads, or transitional aged care packages, where we can deliver exercise programs to people's homes, so that we ensure that they age well and that they maintain their independence. In some countries, such as Japan, robotics are used and are a future option for assistance in the home. And here, this lady is using a robot to bring her a cup of tea, which I think everyone would probably love to have. Could you just show the YouTube video about tele-rehab in Australia?
Statewide telerehabilitation is really about providing telehealth solutions for consumers across the state to access their rehabilitation program at home or in their local community, just to make things easier and more in context and make sure that their rehab fits into their home lives. Last financial year, we had over 1,000 consumers across the state access more than 5,000 video-enabled rehab services. They tell us that this is a really effective and efficient way and a really supportive way to provide their rehab. So I've got lovely stories of consumers who can undertake up to 3 sessions of rehab at home and not need to travel. So the costs of travel accommodation, the safety aspects, the ability for consumers to do this in a way that makes sense with their support network around them makes it a really successful journey. The interest in what we're doing across other programs within SA Health is really huge. We've just started service delivery for tele-rehab with the Women's and Children's Network, so for paediatric rehab in this state, as well as actually growing into palliative care and other programs.
In that video, you can see the delivery of services by tele-rehabilitation. This can also is being done through mobile phones, which is why it's so important for older people to have some education about the use of mobile phone and assistive devices. Slide. So one of the things that you can do to ensure that you have better options for healthy aging is to use your vote or your influence to improve opportunities. So we need to have access to immunisation. Of course, we need it for COVID, but there is vaccinations now for meningococcal disease and varicella, which is shingles. So diseases that can affect older people, you can be vaccinated for. You also need to have access to healthcare for diabetes and hypertension or high blood pressure, which tends to occur as you get older. We need to get our vision checked, and I'm going to show you a short video of that in a moment. We need to make sure that you influence governments with so that older people get access to public transport so they can get around, and also better access to mobile phones. Here is a South African farmer who is on his own and using a mobile phone to get contact with other people. Also, public spaces need to be easy to get to for older people so that there's not a lot of stairs that prevent you from getting to places or not a long way down to climb to get to an area where you can sit with others and have a meal or talk to them. We also need to bring our influence to bear about the disparity between health services in rural settings and metropolitan settings. So, and we need to keep a focus on minimising smoking and alcohol, and also stopping older people being exposed to smoke a lot. Housing, of course, will improve people's quality of life and their ageing. And we must note that as fertility rates have dropped around the world, and particularly in China where there was less children born, it meant that there were fewer caregivers as people got older. So social supports like pensions are now being deployed in many Asian countries. Jessica, can we see this slide of, this is a slide of Professor Hollows, who helped people find their vision all over the world, a great Australian.
What did he say?
He says you can see quite well.
The thing that characterises human beings is that human beings know about charity. They know about looking after the halt, the lame and the blind.
slide, thanks. Yeah, Professor Hollows dedicated his life to trying to restore vision to as many people as possible, and he did so by teaching other doctors how to provide healthcare and improve the vision for older people as well as younger people. Slide. So the main themes are, it's important to maintain your independence for healthy aging. You need to be as active as you possibly can, and you need to be involved with social interactions as much as you can. Isolation is something that will not be helpful if you want to age in a healthy way. Continuing to learn, particularly about information technology, is important. And if you can do voluntary work or part-time work, this would, of course, improve both your quality of life and also keep you relevant for the community. This is really important for healthy aging. As we age, we need to maintain our relevance through activity. We all need to have access to well-trained healthcare, and of course, we need good nutrition, particularly diets that have proteins in it. This image is of the Blue Zones, which is an American project in which they studied a group of communities where there was a large number of people who were aging in a healthy way. They were from California through to Italy, Greece, Costa Rica, and Okinawa in Japan. And each of these different groups had something about them that would make them seem to have larger numbers of people living into their 90s or into their 100s. It made me think about a country clinic that I attend in Foster, New South Wales, slide, which is about 3.5 hours from Sydney. And I noticed, I want to tell you about a patient of mine. Her name was Sandra, who she used to love bowling. This is a game that older people play in Australia, but she was very competitive, and she travelled to compete, and she used the bowling club as a social setting for her. She had a lot of friends, and she came to me because she gradually developed back pain and needed to see a rehabilitation physician for that. When I examined her, I found that one of her joints was inflamed, which I can show you in this diagram on the bone scan. And it struck me that from this position, she would be moving that joint very often. And as such, she'd had an injury to do with her sports. Her activity had brought her love of the activity had brought on a bit of inflammation of that joint. So we gave her medication. We got her to do hydrotherapy. We gave her some exercise, and we also introduced her to our psychologist. And within 3 months, she started to play bowls again. So I wondered whether Foster, in some ways, our blue zone in Australia. Slide. In Foster, the mean age is 61.6 years, which makes it the oldest area in Australia, or the area in Australia with the greatest number of old people. I noticed that I had a patient who was 102 who had told me that she took up golf at the age of 80, and she now would attend the rehabilitation centre for a boxing class twice a week. She does sit down as she boxes, but she's strong. I have a 99-year-old patient who demanded a hip replacement operation, saying that she would rather return to independence than go on with ongoing pain. And she got her hip replacement and returned to her usual function, living on her own. A 98-year-old man keeps his family together and is driving down to Sydney for Christmas. And I wondered, why is it that so many people in this area live so well as they get older? And I realised that there's good facilities. There's a rehab hospital, there's aged care services, and a lot of general practitioners, a lot of doctors. There's a lot of leisure. There were 3 golf courses, and there's 3 bowling clubs with inexpensive food, so that people who were on a pension in Australia could have a decent cooked meal at least once a day with a bit of protein in it. There's an aquatic centre, a number of social clubs, and as you can see, there's beaches and lakes, and there's sometimes giant whales that come into our lakes. But our only problem in Foster that makes us perhaps not a blue zone is that all the clubs serve a lot of alcohol. And whilst in many of the blue zones, such as Sardinia, people do drink 1 or 2 glasses of wine a day, drinking excessively would probably not be a good part of healthy aging. Although it is hard to argue whether drinking small amounts would be of benefit. Slide. So rehabilitation teams and physicians can assist us to age well. They can ensure recovery when there's an interruption to our independence. They can promote independence. They can make sure that exercise and nutrition and good health care is available in many different settings and in many different forms. They educate, particularly about information technology. They advocate to make sure older people can get access to public places and transport. And I hope that as we all age, we keep these principles at the top of our mind, and we all have engagement with some rehabilitation services at some stage. So thank you very much. Slide. And I want to encourage people who are interested in this event to submit a video or register for the event for the remaining days. Thank you so much, and it's been a pleasure and an honour to speak to you.
This was a very interesting topic, and it is so important for us to apply some of these clinical practices, such as healthy nutrition and exercise from an early age to have a positive impact in healthy aging. So thank you, Professor Fo, for your presentation. Unfortunately, Professor Fo cannot join us for the question and answer session due to the time zone in Australia, but you're welcome, and please feel free to write your questions in the question section. We will ask him to answer later via email, and they also will be posted on our event page afterwards.
Very good. Now, our third session and final session for the morning is the falls and injury prevention by Dr. Antona Yadu.
Good afternoon to all. Thank you for joining the ISPRM Rehabilitation Wing and the lecture Falls and Injury Prevention. I'm Eleftheria Antoniadou. I'm a physical medicine rehabilitation physician, currently working in a geriatric rehabilitation unit in the Centre Hospitalier du Nord in Luxembourg. With this lecture, we're going to analyze the falls and the problem of falls and to see what we can do about it. So is it a problem? Is falls a problem? Well, falls is a major health problem among older people. Why? Because 1 out of 3 people aged 65 years or more living in the community falls every year. And if we go to the octogenarians, 50% of them are falling. Females fall more easily than males, but the consequences, the most serious consequences, as you can see, are in males in all decades. Falls are the #1 cause of mortality for older people regarding trauma, and falls are the major cause of hospitalization and loss of functional autonomy in the aging population. And if you fall, this is the #1 risk factor that you will fall again. So I think I convinced you that it is a major health problem and we should do something about it. It is also a very complicated problem. Why? Because Underneath the fall, it's the balance control, which is a very complicated system. It is a kinetic dexterity that has a lot of components. It starts with the sensory system, which is in place to inform us about the stimuli from the exterior. And so our vision, our vestibular function, labyrinth, our sensation of cold, warm, pain, touch, and also our proprioception are all gathering information from the outside world to the cortex, to the sensory cortex. And from there, the sensation goes to the information of the sensation goes to the motor cortex, and there the motor plan is formed. From the motor cortex, the pathway down to the spinal cord, and then through our nerves to our muscles to give the final answer to the stimuli. So this is how, of course, in not many details, the balance control is done. And in all this, there is a limbic system that is formed, and this does give to our balance control our emotional reaction. So if it was a bad experience, if we are falling, that is going to be and register as something bad, and fear will arise. And that is very, very important, as you can understand. So to all this complex system, changes are happening with aging. And in all of it, and not at the same degree in the same person, and not in all of us, all the changes, but changes are happening. And of course, in that, we have to also consider the burden of the diseases that they also come with aging, and sometimes, of course, side effects of medications. So we should diagnose what is going wrong, and what we're going to do about that. We will start, of course, with a very thorough history about your falls, about your diseases, about your medication, and of course your family history, and a very thorough clinical examination to see your neurological responses, your musculoskeletal system, your vision, your vestibular function, special maneuvers also sometimes will be done to you to see if there is something wrong. But that is not enough. Usually, to be able to diagnose what is going wrong, we will need to do some special testing, and in very sophisticated laboratories, also some dynamic platform testing. The special tests can be done if they are just an early detection test. It's the first line of test, can be done in every doctor's office. It just takes some time to see whether there is actually a problem with your balance. And these are tests that they are fit for the purpose, and the Romberg test, the timed up and go, the tandem walking. And you will be asking the Romberg test to stand up, close your eyes, and maybe your physicians will push you, but he wants to see if you're tilting or not. The timed up and go, you will be asked to sit in a chair, then stand up, walk 3 meters, turn around, and go back again and sit again on your chair. And there will be your physician with the stopwatch and counting the time that you need to do all this. Of course, if you do it in a very big time, this is a problem, and then you will need more testing. And more testing is more sophisticated testing. This test, that they are the next level of testing, they must be done by somebody who's experienced, because sometimes they also need equipment, but experience is very important to accurately rate them. And there are a lot of them, but we use mostly the genetic test, the birth balance test, the MCT-SIB, and the mini-best test. Here, this is our wonderful physical therapist, Jessica Penning, who is doing a genetic test to an older person in our clinic, and he is moving around with his aid, and of course the obstacles. This is part of the test, it's not the whole test, and conclusions will be drawn after the test on what is going wrong. But other tests will be also done, like tackle the fear of falling test, because as we mentioned before, they're very important to see if you have a fear of falling. And as we also said, in sophisticated laboratories, they have dynamic platforms. The tests like they will be done to you. They have to be, of course, studied enough, because sometimes this is the problem, and to draw conclusions. And also there are also other tests like wearable sensors, EMGs and platforms, cognitive cues, and that the list goes on and on. But this is more research than a clinical practice. When we have done all that, now we have to do something about your fall problems, and then we will have to manage your risk factors for a fall. Now, risk factors for a fall, there are many. There are studied more than 400 risk factors. And of course, the more we address, the best it is. But if we should address just one of these 400 risk factors, it should be inactivity. So 400 risk factors, there are too many. We cannot talk about each and every one of them, but we can talk about the broader categories of risk factors, that there are biological risk factors, behavioral risk factors, environmental risk factors. Biological risk factors are, of course, muscle weakness or balance problems, medication side effects, chronic health conditions, vision changes and vision loss, loss of sensations of infant and low vitamin D levels. Behavioral risk factors is very important because it comes from the individual. It can be alcohol consumption, poor sleep, improper footwear, risky behavior, inactivity. And environmental risk factors, because I have to tell you the majority of falls happen inside the house, and a house with a lot of hazards is usually, or even some hazards, is usually the problem. Then we should go and treat the problem. But I will have to tell you that the best way to treat the problem is, of course, to treat each problem one by one, or just go into a rehabilitation program for balance. So one by one, maybe it's the better, the whole of it. If you have it in your area, then try to find out if there is a rehabilitation program for fall prevention, and because it will address more than one part of the problem. So in the rehabilitation program, you will have an individualized, of course, protocol, and you will be asked about your medication, and there will be some pharmacological intervention if needed with vitamin D supplementation, or an osteoporosis, anti-osteoporotic treatment, because if you fall and you have very weak bones, this is very easy to have a fracture. Cognitive and psychological interventions if needed, because cognition is very much linked to falls, and there are special tests that you can do to improve your cognition, and psychological interventions. Depression is also very much linked with falls. And of course, exercises that we will see in detail, and ergonomic changes that you will be advised. Some practice recommendations are very important. If you do an exercise program, the exercise should aim to challenge your balance in 3 ways: reduce the base of support, move the center of your gravity, reduce the need for you to grasp something with your limbs, the upper limbs, with your hands, to maintain your balance. This is the very important recommendation. Recommendation number 2 is to have a substance dose and minimum of 50 hours, because if you just do it once, it's not going to have any effect. Recommendation number 3, ongoing exercise is necessary. Recommendation number 4, fall prevention exercise should be targeted at the general community as well as those at high risk for falls. And number 5, fall prevention exercise may be undertaken in a group or a home base. Number 6, walking training may be included, but only in the people that they are not at very high risk of falling, because if you have a high risk of falling and you will fall. And strength training may be included in addition, of course, to balance training. Here is also Jessica explaining some very easy exercises that you can do in your chair, and this is on purpose because chairs gives you a very safe environment to strengthen your feet and your quadriceps and your and she's just doing that to explain it to the people that they are in the fall prevention program in our clinic. But there are also other protocols that you can do. There are Tai Chi exercises. There are also others in the literature. Or you can use the Blackmore, as we have seen before, not only for testing, but also for balance purposes. This is dynamic platform. And this is a lady that she's doing in the clinic, that she's doing a balance protocol for the prevention of falls. And also dance has been proven very well. This is me also dancing with the program that we have done with our older people. And this is Greek dances, of course, but you can use the dances that they are more pleasing to the ears of your community. Also here, this is a very nice intervention. Our physical therapists and our occupational therapists are doing in the clinic. They are doing a group-based exercise for fall prevention, when they discuss all the risk factors, the preventions, and what to do. Don't stand up very quickly. Take care of your house. And because why they have a lot of course about ergonomics, because this is a very busy picture with all the possible hazards that the older people can have in his own house, rugs that they put in the floor, wires, tables, and stairs without side rail, and the list goes on and goes on. These are very important problems that we need to take care, and inform people also in group-based is easy. Also, they told me that people are afraid to talk about their falls. They are ashamed. And so if they are in a group and one starts to talk, then the other ones talk about their experience with the fall, and this is going very well. Thank you for your attention. This is our purpose, to make our elders feel happy and in good health.
Okay. Thank you, Professor. Hello. Thank you, Professor Tatiria, for your nice presentation, interesting presentation. I think it was fruitful and full of nice informations. And maybe now we can start, begin the question and answer session. And everyone is invited to put their questions in the question section or the chat section. You're welcome.
It's just a reminder for everyone who has questions to put them in a question box so that Dr. Antoniadou can answer them. So we have one question for now. It's, what are the most frequent comorbidities related to risk of falling in elder patients?
That's a very good question. I should say dementia is one of them. That's why I wanted to stress the cognitive part of the protocol of prevention of falls. Of course, broader neurological conditions that can have an impact in the mobility of the person present with falls problem, and sometimes a poorly managed blood pressure that gives hypotensions can be also linked to the problem of falls. But there are many falls that we don't have a disease to link with. People are falling and we cannot find the cause of it. And there are a lot of those. So we will of course, we will have to analyze all the, to do the clinical examination, the history and everything, but we also have to focus a lot of the problems of falls as a condition per se, and not linked to any other condition.
Thank you very much. So another question we have for you is it a good clinical practice to refer every patient that has fallen to a psychology department, even if they have no sign of fear of falling?
You should also do not only the fear of falling, but also to see if there is any depression and then treat that. Sometimes I saw that in my practice, a lot of people with depression, they come for, they don't want to talk about the depression and they come for a problem of falls. But in the comprehensive geriatric assessment that you should do whenever you have an elder people in your clinic, there is also a part that you should see if there is any depression and any other problem of psychological problem in the older person. So just do a GDS and geriatric depression scale to find out if there is any problem there, and then refer that to the person to the psychologist. Otherwise, you will do a program and it will not have any effect.
Thank you. We have a third question. How important do you consider the vestibular rehabilitation in these patients? This question is from Mariana Arocena. Go ahead.
Thank you for the question. The problem, if there is a vestibular problem, is the only thing that you have to do. You have to find out the problem and you have to do vestibular rehabilitation. But sometimes also, people, for example, with multiple sclerosis, they have a problem of falls that is not related to a mobility problem, and you should always go and check vestibular function. It is not very obvious, but sometimes you can see there is a problem over there. So vestibular testing and vestibular rehabilitation, they always have to be part of the history and of the physical examination of a person with a problem of falling. And if of course this is the problem, you should do vestibular rehabilitation. It's very effective also.
Professor, if I might ask, since we know that strength training can reduce the risk of falls, what specific muscle groups do you focus on, and at what resistance for the elderly?
That's a very good question, because actually what we know about exercise is that it's balance exercise that reduces the risk of fall. But you should do some strength training with balance exercise to have an effect, because you cannot just do balance exercises and you have a person who does not have a good strength. So the first thing that you should do always is safety, because older people and fallers, you should always start to think about safety. So do not ask people to walk. I saw that many times. It's a very easy thing to say to older people, go and walk. No, you should start by strength training, big muscles, safe, and if it's in the presence of frailty, I would go to low and medium intensity, 30 to 60% of one repetition maximum and not more than that. And I would start with 30 if it's a very frail person. But if you have a robust older person, then you have to go up and 70 and 80%, and of course increase the program accordingly to the effect and to the response of the person. But please keep in mind, don't ask fallers to walk, they will fall. That is very important. I saw that a lot of times.
We have one other question from Diane. Go ahead.
No problem. I just want to ask her, do you recommend to establish a prophylactic dynamic balance exercise the part of primary health care beside the vaccination? We were in the last presentation, Professor mentioned to have the aging people. You recommend that?
I did not really well understand your question. Can you please repeat? If I recommend what?
To establish a prophylactic dynamic balance exercise program for the elderly as a part of the primary health care.
That is a very, very good question. I don't know if prophylactic is there is anything in the literature about prophylactic exercise programs, and because usually the programs are we have folders, we have to do something about them, but so I cannot tell you if I recommend it or not. It's not something it's proven. But it's a very interesting point because older people, they lose their dynamic way to respond. They are slower. They are not very. Their muscles is the part which is the fast part of the muscle is getting slower and it's not responding very well. So this is a very interesting point, but I'm not sure there is in the literature something that can make me recommend it or not. So I leave that open to the discussion or to the community to answer it.
Thank you. I think we have time for one more question. We have one from Diana Popa. The risk of fall is high in young people with disabilities as well. How do you assess the risk of fall in this category, and what tools do you recommend?
Usually, I think the tools that we need, the scales that they are proven are the Berg balance scale. It is always that. Also, the TINET is not. It's not only for older people, but for example, the mini best test is better for older people. The Berg balance I would recommend it more for younger people with, for example, a stroke. This is because the literature is using them more and more, but you should always do a more comprehensive testing. I mean, they're very important, don't get me wrong, the timed up and go, the tandem walking and the functional needs test, which I personally don't like it very much. But if you want to test and have good results and to know what to do, you need to do a comprehensive test. So you need to have the time, the experience, and maybe the equipment to do a test that it takes more time, like the Berg balance, the TINETI, the MCT-SIB. Because otherwise you won't have information enough to start your rehabilitation protocol.
Thank you very much, Dr. Antoniello. That was a very interesting topic. We just want to ask the audience if you could please remain connected for a few moments to answer our 3 poll question. We're going to conclude the question and answer segment now, but we're going to ask you to answer this poll, please. Thank you to everyone, and thank you again to Dr. Antoniado. We have some more questions. If you could please answer them in a written form.
Okay, I will. Thank you.
Thank you very much. So to conclude our first day of event, we will play a video from Dr. Francesca Gimigliano from Italy, Dr. Melissa Selb from Switzerland, and Dr. Masaiko Mukaino from Japan on behalf of ISPRM's CleanFit Task Force. This video introduces the work on developing CleanFit COVID-19, an ICF-based clinical tool for the assessment and reporting of functioning of patients and survivors of COVID-19 for rehabilitation and enhancing it through the international data collection.
On behalf of the ISPRM CleanFit Task Force, we would like to inform you about the work on developing CleanFit COVID-19 and enhancing it through an international data collection. With its Rehabilitation 2030 call for action, WHO has spearheaded a major effort to strengthen rehabilitation in health systems all over the world that also includes functioning information. To address the need for a universal tool that can be used by rehabilitation professionals worldwide, ISPRM's leadership embarked upon an initiative to develop, implement and maintain an ICF-based clinical tool for the assessment of functioning called CleanFit. To support this work, the ISPRM leadership established the CleanFit Task Force, comprising of ISPRM members from all 6 WHO world regions, with both clinical and scientific expertise. CleanFit can be tailored to the specific needs of clinicians, for example in the current context of COVID-19. COVID-19 continues to challenge public health with fluctuating case numbers, unfortunately surging in colder months. Older adults and persons with underlying health conditions are especially vulnerable. This population is at higher risk of developing severe forms of COVID-19. Thankfully, there is rehabilitation. According to the document you see here, rehabilitation optimizes health and functioning outcomes of COVID-19 patients. Given this, there is an urgent need to develop an ICF-based clinical tool for the assessment and reporting of functioning of patients and survivors of COVID-19 for rehabilitation to assist health professionals to optimally address their healthcare needs.
In a first step, we conducted a survey in 2020 asking ISPRM members for feedback on ICF categories that the tool should cover in the acute, post-acute, and long-term context. The results were published in the Journal of ISPRM, and we prepared a user manual introducing the pilot version of CleanFit COVID-19 with 3 rating scale options. The manual includes the 9 versions of CleanFit COVID-19 for the combinations of the 3 rating options with the specific acute, post-acute, and long-term items.
With this manual, we plan to test the first version of CleanFit COVID-19. Main aim is to develop an interval scaled functioning score for COVID-19 and to evaluate the feature of functioning profiles. In January 2022, we will start applying for AS6 approval. If you are interested in getting involved, you are welcome to contact
Dr. Burke, we are not listening to you. You have to.
I think that Burke has, we can't hear
I
you.
was speaking to myself.
There you
Now
go.
I'll speak to everyone. Thank you for joining us today. We look forward to seeing you tomorrow and hearing you tomorrow. Please remember to share on social media the hashtag ISPRM Rehab Week and check out the program available online. So until tomorrow, bye.
Goodbye to everyone.
Have a nice day.